Greetings, I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to the ANA presentation of new tools for a quality of life for acoustic neuroma patients with the team from Mayo Clinic. Dr. Michael Link and Dr. Matthew Carlson will introduce themselves in just a moment. First, I'd like to handle a few quick items. As everyone is watching, should you have a question, you can just write that in the Q&A section, which can be found at the bottom of your screen. We may be able to have those answered as we go through the presentation, but afterwards we'll get to as many as we can. Captions are available for this presentation. You turn those on at the bottom of your screen as well. The presentation is being recorded, so you'll be able to find this on the member section of the ANA website at anausa.org in our member library. That's also a terrific resource for so many topics you may have an interest in. Lastly, a reminder to keep an eye on our social media, all those informative posts on Facebook and Instagram, for the many ways you can learn about the resources available and how you can be more involved with the ANA. As we always say, we are here to help, so we hope that you will access those opportunities. And now, doctors, if you'd like to introduce yourselves, we can get us started.
All right, how's our audio and video? Are okay?
That looks great.
All right, my name is Matt Carlson. I'm one of the otologists here at Mayo Clinic, one of three otologists. I'm involved with vestibular schwannoma surgery and cochlear implants and other ABIs and hearing rehabilitation.
And I'm Michael Link. I'm one of the neurosurgeons here at Mayo Clinic. There's also three of us whose practice is primarily focused in the treatment of vestibular schwannoma or acoustic neuroma. And our group works very closely together, and we're delighted to be with you today.
I'm going to bring up our slides here. Just let me know if they're projecting okay here.
That looks great.
Play, just make sure that is that showing up okay?
Yes, that looks great.
All right. So you may not know this, but a lot of the people on the call right now have actually contributed significantly to the development of what we're going to present right now in collaboration with the ANA. So on the upfront, we'll just thank you for your involvement and your contributions to this. And you'll see as we go through how you've been involved already and how in ways you can continue to shape a lot of these instruments that ultimately influence and impact patients with vestibular schwannomas a lot. So these sorts of things don't happen without the contributions from the people who are listening now. So thank you. So I'm going to primarily talk about where we have been and where we are up until a couple months ago. And then Dr. Link is going to present some exciting things about the direction that things have gone and a new instrument that we have that we think provides a great opportunity to better understand how people are doing and to ultimately hopefully inform the best treatments we can give people long term. If you want to read a lot about more than you ever want to know about vestibular schwannomas, we have a book that we published by TEMA. I don't consider it a conflict of interest because we basically don't make any money from it. But yeah, it has a lot of interesting chapters from a lot of well-recognized contributors from the scientific field in vestibular schwannoma management. It has about 500 some pages in it. And this is a great review article that we published a little over a year ago in the New England Journal of Medicine, and it provides a great overview of vestibular schwannomas in general. The Acoustic Neuroma Association has a really nice portfolio of patient education materials, and this is something that could supplement that if you're interested in kind of understanding kind of our take on the condition and kind of future directions and ways we think about it. So I think we'd like to start out by saying, at least in our fields, in the field of otology and the field of neurosurgery, there's very few things that are more controversial. You'll hear, people that would be considered experts in all these in the two fields provide very different recommendations, and even the ways they think about this. There's statements. I want to say that the statements you're reading in the background are statements that I don't think are usually true. So you're seeing these things in there. I just want to say that we're not endorsing those things. There are things that are commonly said that can shape your decision making that aren't always necessarily true. you might hear from one person saying, well, radiation is the only way to go for a small tumor. Why would you ever have an operation? And then sometimes they'll say, well, you shouldn't have a radiation because it causes cancer, which is very far from a good way to counsel people. But you'll hear a lot of different things. And so a lot of the goal of all this is to try to find ways to provide the best information for you to make the best decision about your care in a timely way and get good care. If you look at the history of vestibular schwannoma management, over 100 years ago, and up until basically really until about 30 or 40 years ago, the only treatments that were really used in a widespread way was surgery, and that primarily came from a lack of different options, but also there was really no understanding of the natural history of the disease, and radiosurgery really wasn't refined very well until the 80s, 90s, and beyond. And so originally people would present with very large tumors which were life-threatening, and you'd only have surgery when the tumor became large. And as a result, because surgery wasn't refined, nerve monitoring wasn't refined, and tumors were presenting late, it used to be a life or death situation. And even with surgery, only the mortality rate was 20% or even higher early on. And thank goodness we've come a long way in all the different fields. More recently, as we've gotten better at removing tumors with less morbidity, a lot of the focus now is on ability to save the facial nerve function or preserve it the best we can. And in a percentage of people who are eligible for it, meaning smaller tumors in the situation of having good hearing, we try to preserve hearing as well. So our priorities have shifted over time, primarily because we've gotten better with things and we have new technologies and ways to manage patients. But what's interesting is the outcomes of our ability to save facial nerve function and our ability to preserve hearing have kind of plateaued. There's probably small advances in those two areas over the last 10 or 15 years or something like that, but they're really similar over the last 15 years. In some ways, we want to continue to get better at those, and I'm sure we will in small ways. But when you look at all those outcomes for facial nerve function and hearing and things, if you take the same size tumor, a lot of the outcomes are the same for all the different treatment modalities. So it's really hard to just say, well, radiosurgery is the best treatment overall, or surgery is the best treatment overall, or observation is the best treatment, because the outcomes have kind of plateaued and they're not a lot different between them. So we've kind of, and probably more importantly, is that's only a small part of the story, whether or not you have good facial nerve function or whether or not you have hearing preserved. There's a lot of other factors that really contribute to your well-being. And importantly, particularly when we're talking about smaller tumors, and even in the medium-sized category, you have multiple options. And so getting the best information you can about all the different aspects of your potential outcomes is pretty important. You can look at what's important to you and your priority and shape your decision-making from that. So these are three tumors that are pretty close to the same. And in these situations, these patients had good outcomes for their treatment choice. The first patient was a 60-year-old patient who had their tumor observed for 10 years and it didn't significantly change, and their hearing slowly deteriorated over the course of that time, but they had good hearing for a while. The second one is radiosurgery, and this was a 55-year-old patient who had a right-sided tumor and received radiation, and kind of similarly, the tumor didn't grow. In fact, it shrank a little bit, which can happen sometimes, and also had a good outcome. And the last patient, even for a reasonable sized tumor, had surgery and the full tumor was removed and hearing was preserved. So it's just to emphasize that you can have a really good outcome with all three treatment modalities, and picking the right one for you is more important than just saying one is the penultimate best treatment for everybody. So what is the best treatment? And that's really what we're trying to get at. And what we're probably learning is there isn't a single best treatment, but we want to understand how we can help you choose the best treatment that maximizes your outcome for the things you feel are most important. This is what we often have seen from a clinician or surgical side. We'll see a patient back after surgery. We'll look at the hearing test before we walk in the room, and we'll look at the MRI, and we'll see there's no tumor there, and we'll see the audiogram is good. We've preserved hearing, so we're very happy about that. And in the back room, we're giving ourselves high fives. We succeeded. This is great. And we walk in the room, and a lot of times the patient also feels the same way, but they don't always. Sometimes there's other things that you don't see on an MRI or a hearing test that significantly impact them. So tinnitus or headaches or dizziness, these other things that we don't track as high as strongly, and we have less control over, can significantly impact your outcome and your well-being. That's what quality of life is focusing on. It's focusing on the less tangible features that impact you a lot, but we don't necessarily track with a test. So an MRI or a hearing test. It's the other things that are also more important. It's your overall experience with the care pathway and your condition. Over time, there's been an increasing emphasis on quality of life in vestibular schwannoma. So in 1980, it basically wasn't a thing. It was primarily focusing on those other things. But over time, we've increasingly recognized that we have to listen to patients and what they have to say to optimize your outcomes. This just shows that we still tend to focus on hearing and facial nerve function. And it's probably because it's the things we feel like we have some control over, a little bit more control over. And still, these other things that impact a lot of people don't probably receive as much recognition as they should from the standpoint of potential patient impact. So what separates a patient who's not doing well from a patient that's doing okay, from a patient that's doing very well? Well, it's a myriad of these different outcomes that you can have. Dizziness can impact a person. Does age impact if you're younger or older? Does the presence of headache, hearing, size of your tumor, ringing in your facial nerve function, or are there differences between genders or sexes that influence outcome? And so those are all the questions we're trying to answer with these inventories. So where have we been in the past? So historically, one of the first and most well-known quality of life measures is something called the SF-36, or the short form 36 health survey. And it was a very good start, and it's still widely used. It's not disease specific. So you could have this, you could take this test if you had arthritis. You could take this test if you had a knee replacement. You could take this test for any single type of condition. So it doesn't ask very specific questions about facial disability or headache or all these sorts of things. So it's nice to compare among diseases. So you could say, like, what is worse? Is it worse to have a vestibular schwannoma or worse to have diabetes or something? You can compare across diseases, but you can't actually, it's not a very sensitive measure within. So patients who have the same disease type, it doesn't really separate them out very good. Another common survey that is used is the Glasgow Benefit Inventory. And similarly, it's not specific to a disease. It asks generic questions that aren't necessarily germane to having a vestibular schwannoma. So these are examples of what you might see on the SF-36. And you might say, for the most part, what does carrying groceries have to do with the vestibular schwannoma? Probably nothing, unless you're really not doing well. But for 99% of people, that's not a substantial separator from somebody who's doing well or not doing well. And so you can easily see by seeing some of these questions how this test isn't as valuable as asking questions that are more relevant to vestibular schwannomas. Some of these questions are good, but a lot of them don't really apply to people with vestibular schwannoma. So these are questions from the GBI, the Glasgow Benefit Inventory. So for a while, we did the best we could with what we had, but ideally you use disease-specific measures, meaning they're specific to the condition. And so in 2010, it was great. The first time ever a disease-specific quality of life measure was published for vestibular schwannomas. And this was a very significant step. For the first time, we could really separate out patients to see who was doing better or doing worse among patients with vestibular schwannomas. Interestingly, the SF-36 and the Glasgow Benefit Inventory couldn't even tell if a person had a vestibular schwannoma or not, meaning if you had a vestibular schwannoma, even if you weren't doing well with it and you didn't have a vestibular schwannoma, it actually didn't really give a distinguishing score. So that just means that the measure is not sensitive to the condition. So if the test you're using doesn't measure what you're trying to measure very well, naturally you could understand that the data you're getting from it isn't as valuable. So that's why the PanQual was a major big step for in the field. As soon as this came out, we were pretty excited about it, and we wanted to use it to measure quality of life. So very early on, 2010, 2011, 2012, we developed a prospective quality of life survey that we delivered or distributed with large help from the Acoustic Neuroma Association. Probably about 20% of the people that fill it out are from the Mayo Clinic or receive care at the Mayo Clinic, and the rest are from the general, mainly general U.S. population, but we do have international survey respondents as well. We performed a number of these tests in conjunction with a group in Bergen, Norway, who also are keenly interested in vestibular schwannoma quality of life outcomes. So since basically over the last 10 years, we've been studying this very closely using the SF-36, the Glasgow Benefit Inventory, as well as the PANQOL and several other symptom-specific quality of life measures, and really found some interesting things. This is probably the first big study that we published from our data, and this, again, was in conjunction with our colleagues in Bergen, Norway. It had over 500 patients with vestibular schwannomas, and we looked at outcomes within these groups. And the main punchline, besides showing that the PANQOL was much more sensitive than the SF-36 and the Glasgow Benefit Inventory, is the main thing we found was that there, on a population level, meaning if you take hundreds of people in each group, there wasn't one treatment that was substantially better than the other. And this was pretty groundbreaking in the vestibular schwannoma world, because there were pockets of people that give treatment that swore their treatment was the best by far, and they would, and patients would be counseled as such. This data quite convincingly shows that when you take hundreds of people in all the groups, everybody does just about the same, meaning there's not one treatment that's substantially better than another. This graphic here is also helpful because it also shows, if you look at the blue bars versus the yellow bars, it shows, you can see there's a big difference between those. And it just shows that the PANQOL, being a disease-specific measure, is pretty sensitive for telling differences between people with tumors and without. So it just demonstrates the value of having a disease-specific measure. This is something that we always stress that's important. If you do a study that has 1,000 people in it, even very small differences become what we call statistically significant, meaning we think that the differences are not just by chance, but there's really something to it from a scientific perspective. But more importantly, oftentimes those small differences don't mean a lot to us as clinicians or to patients. So, you know, if we said the chance of getting a bad headache after surgery was 5% or 5.5%, you might say, well, that's not a big enough difference to drive my decision making about one treatment or another. And we would agree with that. But maybe a difference between 5% and 20% does mean something to you and to us. And so you have to look beyond just a difference based on a statistical outcome, and also say, does it actually matter to a patient to have that difference too? And so that's what, whenever you look at outcomes, you have to not just look at in the lens of statistics, but also what matters to a patient as well. So that's what the MCID is. I'm just going to show you, we basically, after this study started, this prospective study started, we kind of took a journey down multiple and answered many different questions that we could for the first time really ask because of this, having this measure. So one of the questions we said is, well, okay, there's really no big difference between treatment outcomes on a population level, but is there one or two factors or one or two outcomes that really determine how a patient's doing? Meaning, is it worse to have really bad tinnitus, or is it worse to have really bad dizziness? Or is it worse to have really bad facial nerve paralysis, or worse to have really bad headache? And so probably an important thing to say is hearing loss is in facial nerve paralysis overall is more common than having worse dizziness. But if you have really bad dizziness, or if you have really bad headaches, those had a higher impact than even having hearing loss. So everybody doesn't want to have facial nerve paralysis. Everybody doesn't want to have headache or dizziness or anything. But if you had all those things, the ones that really increased a person's likelihood of having to go on disability or not doing well was a severe dizziness or severe headache, which was also kind of a new feature. We always thought that the worst thing in the world were the things that we could measure, the hearing loss and the facial paralysis, which are very important to us and to you. But if you rank these things, those have a bigger impact on your overall daily well-being. And this is just a couple different ways to look at that from the PANQOL and also the SF-36. This is getting in the weeds of the numbers, but they all kind of had a similar result. And then we said, so we found out from that study, the fun thing about this research is that one question leads to another. There's different types of research we do. Sometimes we just have a single question and we do a study and we have an answer and you kind of move on and you do something else. This research is kind of taken on its own life. You answer one question and then it leads to 2 or 3 more questions, which leads to 2 or 3 more additional questions. And so we're just going down this line of questioning and finding answers along the way. So it's actually a lot of fun. It's almost a story rather than just an answer to a single question. So if we ask the question, what are the worst symptoms if you have them? And it turns out dizziness and headache are the worst. And so then we said, okay, well, what predicts having really bad headaches or having really bad dizziness? What's interesting is the strongest prediction of how you're going to do after treatment is how you are before treatment. And actually treatment can change how you are, but if it's done well, in many ways, it doesn't. Really, the goal of treatment in most situations is to try to keep you as much the same as you can be and not make you worse, rather than make you substantially better, at least for vestibular schwannomas. So for headache, being younger, having a history of anxiety or depression, or having existing headaches before treatment was the strongest driver of having bad headaches after treatment. Initially, right after treatment, you're more likely to have pain after surgery. And of course, that makes sense. You just had an operation with an incision. But if you follow people out long enough, actually, there's no substantial differences in headaches when you get out years after the treatment. But in the short term, of course, pain's a little bit worse after surgery than other things. And then this is the same question that we asked for dizziness, like being unsteady after vestibular schwannoma treatment or from having the tumor is not uncommon. But how about having really bad dizziness, the type of dizziness that keeps you from going out and things like that? What factors predicted that? Female gender, being older, having a larger tumor size, or pre-existing dizziness or headaches predicted having worse dizziness after treatment as well. So early on after an instrument's released, you can't have prospective data. Prospective data means you followed people over many years to get your outcome. And that's the holy grail or the gold standard in research, is having prospective and even randomized, which is even more difficult. But so early on, we did cross-sectional studies. So we looked at a snapshot in time. But over many years, we've been able to aggregate longitudinal data, meaning over time data. And this was a study that came out not too long ago that looked at patients over time. And it gives you better data, mainly because you have a baseline. So you have the same patient before treatment, and then you have that patient after treatment, instead of just taking a large group of people after treatment and comparing them across each other. And this actually showed a similar story. Overall, before treatment and after treatment, people didn't actually change very much when we followed them out for a long time. In fact, on a 100-point scale, when you look at a lot of patients, there were only 1 or 2 point differences overall. So that means like you're going from a 70% to a 71% or a 72%, which is a really small change on a population level. There were a couple things that had small changes. One thing that's interesting is there does appear to be a benefit to a small percentage of people who have surgery from a psychological benefit of having the tumor removed. There is a percentage of people that improve from an anxiety level just knowing that the tumor is removed and having that, quote, cure. You get another MRI and it's no longer there. But overall, the differences are pretty small. If you look at people along your whole journey of having a vestibular schwannoma, when you first are diagnosed, you worry about what's going to happen. Worrying about what's going to happen actually creates the worst time in your whole journey for having a tumor for most people. It's that uncertainty. You've just been diagnosed with a, quote, brain tumor. Whenever you think about brain tumor, you think about significant complications and even death. And of course, the vestibular schwannoma is not that type of brain tumor. It doesn't, today, those sorts of bad outcomes are very uncommon, but it does create that initial anxiety. So what's interesting is the worst time point along a person's journey for a lot of people is the day you were diagnosed. and it gets better after that because you've settled into your diagnosis a little bit. You become aware that it's not going to grow very quickly usually, and you become aware that there's a lot of good treatments for it, and you become aware that you'll probably do pretty well in most cases long term. So a lot of very interesting things that have come out of this that we couldn't get from just studying your facial nerve function, or we couldn't get from just studying your hearing and looking at audiograms. These are not testable questions without using these inventories or these measures. One question we get a lot from patients when they come in, they'll say, I have this symptom, and if you can give me a treatment that will make this symptom go away, that's the one I want. Or they say, I'm doing pretty good right now. I don't want a treatment that will cause this symptom. And so, and that's their driving question. They'll say, I have really bad headaches. Give me the treatment that's most likely to make my headaches go away. Or I'm really afraid of having dizziness. I don't have it now, and I'm really afraid of getting it. What treatment is most likely to prevent getting worse dizziness later? And really, the really big thing that comes from this is all of this is tying together. We see kind of an answer in one question, and we see it repeated a little bit in a different question in a different way. And what it's telling us is that our ability to modify your symptoms with the treatment are actually pretty poor. And if you have bad symptoms beforehand, the treatment largely doesn't make that symptom better. There are exceptions to that, a really big tumor that is pushing on the brainstem and things like that. But removing a tumor doesn't make hearing better. Removing a tumor usually doesn't make tinnitus better. Getting radiation usually doesn't make tinnitus better. Removing a tumor usually doesn't make dizziness better. It can sometimes, but we never promise that because there's some uncertainty around it. And I think that's an important punchline of all this. So kind of summarizing where we have been to where we are, we've come a long way, beginning with just reducing the really bad complications with treatment. And then our next big improvement came from our ability to listen to patients and have patients tell us what's important to them, because it's not always what we think is important. Sometimes there's things we think are not as important or we prioritize, but you say, no, those things are more important to me than other things. And so that's led to quality of life study. But through our journey over the last 10 years, using the PanQual, the quality of life measure for vestibular schwannoma, which is a huge improvement over having the SF-36, we've learned that there are a couple shortcomings, and that was the motivation for developing another measure. And it was actually from having the thousands of responses. So what happens is we send out the survey to you, and you fill it out, and you can answer all the questions, but you'll say, but wait, you didn't ask about this, and this was a big deal to me. And so it's all those responses that helped us develop this new inventory, literally thousands of comments from patients, and also having a patient advocate representative that works in the ANA also contribute to this, that we feel this probably or hopefully asked some additional questions that weren't maybe asked in the PanQual. And we'll see with time if this new inventory provides the additional benefit. We think it will, but we'll need to test it. And so that's the baton handoff to Dr. Lincoln. He'll present to kind of, I'll share this here. He'll kind of present what we've come up with this new inventory. So let me find new share, I think. Let's see, is it F5 or down here? Is that projecting okay? Hopefully it looks good.
Okay, so that's a great background, of course, in sort of why we're so enthusiastic about this research. And I think, of course, the logical first question is, well, we've got the SF-36 and the Glasgow Benefit Inventory, which we've heard aren't really good for acoustic neuroma. They don't ask the right questions, but then this Penn Acoustic Neuroma Quality of Life, or PanQual, came out, and that really has helped us a lot. But there are some issues that we noticed going along that prompted us to want to try and develop an even better measure of what's really quality of life in acoustic neuroma patients. Once again, we don't have any financial interests in any of this. I will add that all of what we're going to talk about is freely available. So this new instrument, we've made it what's called open access, meaning your doctors can get it, you can get it. We don't get any money from it. It's not for sale. It's just available now through PubMed or any other literature search engine. So as Dr. Carlson noted, we've shown that these other instruments can't even figure out who has a tumor and who doesn't. And I got to say, surprising to me, and I'll even say to us, is there's very little difference in outcome between very different treatment modalities. I'm sure as everybody on this webinar understands, having a major intracranial operation is much different than doing nothing or having a one-day outpatient radiation treatment with gamma knife, for instance. So why aren't there differences? And it could be that there really are no differences. It doesn't matter what you do, you will end up in the same place, or it could be that we're not asking the right questions. And once again, this is that graph that Dr. Carlson showed. And one of the things it shows is this whole issue. So the blue bars are normal controls, people without acoustic neuromas, and the yellow bars are people who have acoustic neuromas that were treated with one of the three modalities. And then the red bars were just the radiosurgery patients. The light green bars were the observation, and the dark green are the patients that had microsurgery or open surgery. And for the most part, for anxiety, for general health, interestingly, for hearing and for general energy, there's no differences between the groups. Now, the patients who had surgery did a little worse in the facial, balance, pain, and a total score. But you see the difference in the score on a 100-point scale is only a couple points. So observation did 2 points better than radiosurgery, which did 5 points better than microsurgery. But it turns out that although you can make that statistically significant if you have enough patients, enough numbers to compare, there's a thing called a minimum clinically important difference. And we looked at that for the PanQual, and it showed that you really needed a difference of 11 to 12 points for, if you were to say to me, what's my quality of life today? And I said, oh, it's about an 85. And tomorrow you ask me, and I said it's about an 80. It turns out that isn't a significant difference. You can't really feel that difference. You have to get at least 11 or 12 points on that particular scale on the PanQual. And again, those are just the differences between observation, radiosurgery, and microsurgery. All fall less than that 11 or 12 point difference. And once again, even looking at it prospectively, there's only one potential advantage to one treatment, and that is patients who underwent microsurgery had an improvement in their anxiety score. So is it that we're not asking enough people about this? And I would say, I think we've overcome that mainly through the help of the Acoustic Neuroma Association. We now have thousands of patients in our database who are filling out the PanQual prospectively. Is it that the questions we're asking aren't sensitive enough to pair out the differences? That may be an issue, and that's what we wanted to investigate with this new instrument. Or maybe, like I said, maybe there is no difference. Maybe the treatment isn't as important as we think it is because all the treatments are good, all the outcomes are good. So we started on this journey, and I'm going to get a little bit technical maybe, or I'm going to get a little bit into the weeds about how we did this to just let you know what really goes on, how difficult or involved it is to come up with this, because I'm sure as patients, you're wondering, why don't the doctors know this? Why can't the doctor just tell me what is the best thing for me to do? So when you want to make a new quality of life instrument, there's sort of two big phases. One is the content validity, and that is, what questions are you going to put in there? And then the construct and convergent validity, or are those questions really getting to the heart of what you want to know and doing it in a reliable way? Meaning, if I give you this test and you answer it, and I give you the same test 2 weeks later, are you going to basically answer the same? Do the questions make sense? So what we did is we convened a group of what we'll call 8 key stakeholders. So Dr. Carlson from otology, me from neurosurgery, we had a statistician. We actually have a PhD person here who's an expert in making these surveys. We had an expert in balance, an expert in hearing, and a member of Melanie from the Acoustic Neuroma Association, who could give us input about what the Acoustic Neuroma Association is hearing from its members. And we broke it down into domains and subdomains. And we based it on the responses from our 539 patients in our initial study that we showed, who had actually filled out a 239 item questionnaire. So if you do the math, that works out to be 180,000 data points that we looked at. And then we also reviewed over 1,500 free text comments from Acoustic Neuroma Association patients who would, on their survey, we had an area where you can write in, well, what else do you want to tell us? And basically things that they told us that we thought were important. And this is just what Dr. Carlson and I get every month from Nicole Tombers, who's our RN study coordinator. And it just is a long list of what patients say. Like, for instance, they might say, in addition to the typical background tinnitus sounds, there are times asynchronous mechanical clicks, sometimes like hearing Morse code, and so on. So we just accumulate this information over the years. And we looked at items that had a good correlation coefficient, and we're covering what we thought were key clinical concepts. And we put them into 10 different domains, and we came up with 194 feelings or concerns. And we made sure when we did this that we weren't asking just about radiation or just about surgery or just about observation. And we tried to write it in a way that was very clear and understandable. And of course, we started out with 194 feelings, and it was hard for us to pare it down to 194 questions, you might say. And we knew that that's just too long. People are going to get fatigued. You know, you can't ask people to fill out a survey the size of their phone book, every year. So we initially enlisted 60 patients to look at this, and we picked out 20 that had a low quality of life, 20 a medium, and 20 a high quality of life. So hopefully we were covering the whole gamut of how patients were doing. And we asked them to say, okay, what of these 193 questions are really most important to you? And that allowed us to break it down to 69 items. So we were getting better. And then we administered that to 450 other patients. Again, we split it up into 150 that had low quality of life, 150 what we'd consider to be medium, and 150 high quality of life. And then we did a cross-validation to a bunch of questionnaires that look at specific symptoms. And that's what all these monotonous abbreviations. So there's a dizziness handicap inventory, a facial disability index, a hearing disability index, a hospital depression and anxiety score of the PANQUAL, the PROMIS 10, and so on. And then we just asked people, how are you doing on a scale of 1 to 10 this week, to see if our questions were registering in a good way, or we were getting the answers to the symptoms we were asking about. And then we asked 100 people who just went through this to do it again 2 weeks later to make sure that their answers would be basically the same. We call that test retest reliability. And basically, we looked at questions that were highly reliable, that paired very well with the symptom we were trying to get at. And so then we could narrow it down to 37 items mapped to basically 7 domains. Plus, we wanted to include 3 questions about employment, because that's never been asked. And we hear that a lot in the clinic. Of course, people say, well, I guess I'm doing well, but I can't do my job anymore because I work up on a scaffolding and I feel off balance. So some people have to change occupations or ask for some kind of way that their employer can change what they do so they feel safer or able to complete the task, and so on. And this is just kind of how it looked at. And there's a couple of interesting things. One thing is, we thought hearing and tinnitus went together, but it turns out tinnitus maps to the pain domain much more than the hearing domain. And this is just an example of some of the questions that we're asking. So we're not looking at audiograms or grading the face based on the House-Brackman grading scale. We're asking people, are you having difficulty localizing where sound is coming from? That's a very common complaint when somebody doesn't hear well out of one ear, or have difficulty understanding speech when there's a lot of background noise. So questions like that is what this gets at. And so it ended up now that the final instrument, it has 5 questions about hearing, 6 about dizziness and imbalance, 5 about pain, discomfort, and tinnitus. And I'll just say, we thought that was very important because we think chronic pain is a huge impact on people's quality of life. And I think we all can relate to that. I think everybody has had a headache. Everybody's had back pain at some point in their life, and it really affects you. The PAN-QoL, for instance, only has 1 question about pain, and it's not very specific. We had 4 questions about problems with the face or eye, 9 questions about impact on physical, emotional, and social well-being, 4 questions about difficulty with thinking and memory. And I think that's one of the things that makes this very unique, and I think is going to be very important going forward. We often hear from patients, I have this brain fog. And it was always puzzling to us, because the area of the brain around an acoustic neuroma, for the most part, we think, doesn't have anything to do with our cognition. But it turns out it might. It turns out that the cerebellum, for instance, which makes all our movements smooth, makes our handwriting neat, may also make our thinking smooth and make our thinking organized. Also, if your brain is having to do a lot of work to just keep you upright and moving forward because you have to concentrate constantly on your balance, that affects your ability with your cognition. Also, there's now pretty good evidence that if you have hearing loss in one ear, that can affect also things like thinking and memory. We wanted to include questions about, are people satisfied? So we included 4 questions that look at satisfaction or regret regarding their treatment decision. And as I mentioned, those 3 questions about employment. But the employment questions aren't used to give a total quality of life score. They're mostly just to keep track of what's going on with patients. And so this is just some statistic stuff. But basically, it just tells us, is there good internal consistency of these questions? Are they asking a question about the thing we're interested in? And this Cronbach's alpha is a fancy statistical test that'll tell you whether or not you're getting to the bottom of what you're asking, and all the numbers look fantastic. 0.83 to 0.91 is really good. It's ranked on a 0 to 1.0 scale. And then this just shows, when we looked at the questions in our domains, hearing, dizziness, pain, facial function, well-being, cognition, how does it correlate to those other tests I mentioned, like the dizziness handicap inventory? And it turns out the dizziness questions correlate very well with the dizziness handicap inventory, and they don't correlate well with the other domains. So meaning we're not asking too many questions about each domain. We're not making patients fill out too many questions. So we were really pleased about that. And then when we looked at retest reliability, in other words, do people basically answer the same in a short period of time? We don't expect patients' quality of life to change too much in 1 or 2 weeks. It's very reliable in that regard. And these are just some of the questions, just to give you an idea of what we're asking. So, for instance, under dizziness and imbalance, we ask, because of my dizziness or imbalance, I have trouble when I turn my head quickly or look up. Because of my dizziness or imbalance, I am afraid others will think I am under the influence of drugs or alcohol. That, for instance, is a comment we heard frequently from patients over the years. This is another big one. Because of my dizziness or imbalance, I do not feel confident while driving. It's a huge disability in our society to not be able to drive. Under satisfaction or regret, things like, I feel I received enough unbiased information to make a good decision about how to manage my vestibular schwannoma. Under hearing, things like, I'm worried about losing hearing in my other ear. So that's a thing that we heard frequently. And so what we've boiled this down to is now a 40-question quality of life instrument. It takes about 8 or 10 minutes to complete, so we don't think it's onerous. It's scored 0 to 100, like most quality of life instruments. I'll tell you, it took us about 20 months, and it's really probably closer to about $50,000 when you look at all the statistical costs and so on to do this. And the big question is it going to find differences between the different modalities? And can it help establish improvements in domain-specific or global quality of life outcome among treatments when stratified by baseline features? What Dr. Carlson was getting at, I think what you all want to know, what we want to know, is when somebody comes in and says, I am so dizzy, I can't do my job, or I'm not enjoying my life, could we figure out, well, maybe this treatment is better for that? So that's what we hope to answer in the future using this new device, this new questionnaire. We just published it a couple months ago in the Journal of Neurosurgery. We paid a fee so that it's what we call open access, meaning anybody can get to it. It's available so your doctors can use it, and you can look at it, and so on. And these are just the group of people. Again, Dr. Carlson and myself. Christine Losi is our statistician. Nicole is our study coordinator. Devin McCaslin is an expert in imbalance and dizziness. He's now at the University of Michigan. He was here with us at Mayo. Anakit is the audiologist. Melanie works with the Acoustic Neuroma Association, and Kathleen Yost is our survey expert. So that's kind of an overview of where we've been and what we've done and where we hope to go. And we'd be happy to take any questions.
That was a terrific presentation. Thank you so much. Which is wonderful information. If you want to go, there you go. Stop sharing your screen. And we're back. We've got a couple of questions if you have some time here. One of them was, how far out post-op surgery were the patients that were asked these questions initially?
Yeah, that's a great question. So on the first study we showed where we collaborated with a group from Bergen, Norway, those patients were on average about 7.5 years after whatever they decided to do. So they were 7.5 years from being observed and they had no treatment, or they were 7.5 years from radiosurgery, or they were 7.5 years from microsurgery. So that was a long-term snapshot. And so we thought, well, that's our problem, is because we're looking down the road. So people have gone through this journey and now they're back to baseline. So then we started the prospective study with patients from the Acoustic Neuroma Association. and surprisingly found the same thing. There aren't many differences, at least using the PanQual.
Oh, okay. Was there any information?
Now we looked at them at 6 months, a year, and then every year for the next decade.
Okay. Was there any information there specific to NF2 related to acoustic neuroma?
So neurofibromatosis type 2, despite the similarity of both sporadic vestibular schwannomas, so what most people on the call have, one tumor, NF2, both groups have a schwannoma. That's the only similarity. NF2 is substantially different in that you can develop, you usually develop multiple tumors in the head and spine and even in the peripheral organ systems. And so it's a very different disease, and the questions you have to ask a population with NF2 are quite different overall. There is some overlap, but it's a very different question set. And so if a person with NF2 took this, it would be missing out on a lot of things that they would bother them. And if a person with just one tumor took an NF2 questionnaire, it wouldn't be helpful either, because it would ask a lot of questions that weren't relevant. So despite having a small amount of overlap between the two, they're very drastically different diseases.
Sure. Okay. You mentioned this earlier, but can you share again how this new tool differs from what's used now? Would it be, is PanQual the main quality of life measurement right now?
Yeah, no question. And PanQual has been validated in a bunch of different languages, even so it's used around the world. And we're not casting disparages against it at all. It's great. But it is a bit limited. Like I say, it only had one question about pain. It doesn't ask anything about thinking or memory. It doesn't ask about employment. I think, frankly, I think the way we're asking the questions is a little bit based on patient feedback. And so I think we're going to get to the heart of the matter a little better.
Sure. Those are all the things you mentioned are things that we do here.
Yeah.
So, absolutely.
Right. And we and our goal, our plan is to get this survey translated into other languages. It turns out that's quite a process as well. You would think you would just ask your friend who speaks Spanish, but it turns out there's such cultural differences. For instance, one of the questions was, I have trouble walking around my house about dizziness. Well, a woman in Norway wrote back and said, I live on the edge of a cliff. If I walked around my house, I would fall in the ocean.
Sure.
So you have to make it so it's
Sort of patient friendly in a way.
Yeah, right.
Specific to where they are. Actually, to follow up on what you said just a moment ago, you said how many responses do you hope to get over the next few years? I know you mentioned there were 539 and then 1,500, just text questions, I guess. How many are you looking to get over the next few years?
I mean, thousands. I mean, certainly there's in our world, there's such strength in numbers. So, we probably look at the data, every 100 or 200 patients and see where the trends are going and so on.
And to follow up on that one, how can patients be involved in this and how can they participate?
I think that the main thing we want to emphasize is this was because of the patients who have been contributing, and this was the result of the input. And so it would be nothing without what we've had for contributions, and it will not be improved if we don't have patients continuing to participate. And so the Acoustic Neuroma Association has very generously posted this study with a link so you can be involved in it. Prospectively, it's, I hope, relatively painless. We've tried to make it relatively painless, where you'll get pinged for when you need to fill it out next electronically, and you can fill it out that way. And as we said before, we try to distill it down to just the important questions. And so, the survey is completable in about 10 minutes or 15 minutes or something like that.
Yeah, so the 8 to 10 minutes is not much time at all, and I think it's really valuable as well. Well, those are all the questions. Thank you so much for this presentation. It was very, very thorough. We saw a lot of comments of people just saying how much they enjoyed, seeing all the data. It was so informative. And thank you again for your time today, but also all that you do. You all are wonderful partners with us at the Mayo Clinic. We do a lot of things together, and it really helps us fulfill the mission of the ANA. So thank you both. And also thank you to everyone for attending, taking time out of your day to be with us. We appreciate you spending that time with us, and have a great Thursday. So thank you all.
Thanks.
Thank you.